Hello, everyone. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr.Abby Eblen from Nashville Fertility Center. I'm joined today by my beautiful and what's another B word? Beautiful and come on, guys,
Boisterous.
help me out. Boisterous friends, Dr. Susan
Yeah, that's
Hudson,
yeah.
boisterous from Texas Fertility Center,
Hello.
and Dr. Carrie Bedient from the Fertility Center of Las Vegas. How are you guys
Hey.
doing?
Good.
We're good. It's
Have you guys
almost
been
spring
out?
break.
I
Yay.
know. We're about to thaw out, although we didn't have much of a winter, I don't think, except for a few big episodes of little freezing rain and little snow, but it's always nice to thaw out. You guys got any spring break plans?
We're going to coastal Oregon with some of our friends from medical
Oh,
school, and I am
fun.
so excited because this year, and I don't know how it worked out like this, but it seems like we mostly do pretty short trips, like 3, 4 days-ish. And it seems like most of the places we're staying are right on the water in like California
Ooh.
or Oregon or wherever throughout this year, and I'm so excited.
So
That's
how
fun.
cold will it be? It'll be probably pretty chilly though, won't it? Up north there?
It's really hit and miss. There are times when it's beautiful and there's times when it's not. And because it's in that Oregon, like semi close to Portland, Seattle,
Hmm.
it will be whatever it will be. And so it might be wet and rainy, it might be gray and dry, it might be super stunning, beautiful. So I don't know. I am gonna overpack for
I went
everybody and we'll just see how that goes.
I went to the Columbia River Gorge in Oregon it was actually a meeting I got to stay for a whole week in this cute little cabin. And it was in the fall
Mhm.
because the salmon were swimming upstream. It was
Mm.
beautiful. I think about the only time I've ever been to Oregon. It was a long time ago, but it was beautiful.
I'm
Beautiful.
super excited.
Yeah.
Well, I'm going to Lithuania. I'm so
Oh my
Oh,
gosh.
Yes, so probably about a year and a half ago, my family and I got our dual citizenship for US and Lithuania. And so this is the first time that we're going there to see where our family originally came from. So very excited. So it'll be,
how's your Lithuanian?
I'm sorry?
How's your Lithuanian?
Speak some Lithuanian to us.
I know like a little nursery rhyme that my Oma told me when I was
Oh,
little, and
okay.
I'm pretty sure I would like butcher it for anybody, but essentially
Oh, come on,
it's
Susan. Give us a little
something
taste of
like
Lithuanian.
Veta Veta Polita Kushita Tam David Tam David Tam David Tam David Tamajisha Nevelika Bega 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 Bega, and that's all I know.
That sounds really good to me.
And like I said, I am sure I totally butchered that for anybody who's listening to this in Lithuania, and my apologies, but that's what I remember as a child. But we're
Oh,
so
wow.
excited. We're so excited to go see the country and
Oh,
drive
yeah.
around
That'll be
and see
so
the
much
sights,
fun.
fun things
Yeah,
like
That's
that.
very cool.
fantastic.
Well, I don't have anything specifically planned for March. We're going to Germany this in July, so I'm really excited about that. Meanwhile, I'm having to like put my kitchen back together after a kitchen remodel. So we're still trying to put that back together. So, but
Hopefully everything will
hopefully be
come
in Germany
together.
in the summer. Looking forward to that.
That'll be awesome. Yay.
All right, so we are going to do a question episode today, Susan. And our questions are going to be related to.
Testing. So all about fertility testing. I'm excited about this because there's all kinds of stuff we get to grab on and see what we have different perspectives and probably some things we don't talk about on a regular basis. So our first one is, hi all, thank you so much for taking the time to look at this question. My husband and I have been trying to conceive for 2 years. I'm 26, he's 28. Normal HSG, thyroid panel normal, A1C 4.7, AMH 3.36, but no other testing. I track my ovulation at home, which looks at urine FSH, prostaglandin, E3G, and of course LH. I have an LH spike on cycle day 13, 14 every month with a rise in PDG afterwards. His semen analysis came back as 81.2 million per mil, 34.7% rapid progressive, 24.3 slow progressive, and 64% normal morphology. That's a lot of good shaped sperm.
Yeah, that's unusually high, actually.
My OB-GYN wants to move straight towards Medicaid IUI. Is there any other testing I should ask for before? And do you think Medicaid IUI is the right place to initially start? Thank you so much.
So it
I
sounds
mean,
like she's got unexplained
plain
infertility.
infertility. That's what I was gonna say. You've got unexplained infertility, unfortunately.
Or fortunately, I mean, it's always kind of nice to know, hey, there's not a specific deficit, but it's always is nice to know there is a specific deficit. So you can spin that one in your mind however you want. I would
Glass
suggest
half
glass
empty,
half
glass half
full.
full.
But I think ovulation induction, medicated IUI, that set of things makes the most sense, because if it's truly unexplained, you don't know what you need to optimize, and so you just kind of optimize a little bit of everything. And medicated IUIs are the cheaper, easier, less involved ways to do that. And so that's usually where we start.
I would advise you to do that within reason. Sometimes we see people who come to us from OB-GYNs who do this for a year. I would not recommend that. I would probably recommend 3 to 4 medicated IUI cycles. If you're not pregnant in that time frame, you probably need to start seeing a reproductive endocrinologist at that point, because there's some additional testing we have access to that your general OB-GYN probably doesn't have access to, and start talking about other options, maybe even IVF.
And what other additional testing would you be thinking about doing if she came to see you?
I would definitely be thinking about doing a sperm QT test, looking at genes that are dysregulated that determine how well a sperm can bind to, penetrate, and actually fertilize an egg. Carrie, what episode did we have the folks from Path Fertility talk about sperm QT?
So that was episode number 184.
Okay, so that's one of the additional tests, and based on your individual history and that type of thing, your reproductive endocrinologist may come up with other tests as well. All right, our next question. Greetings from Finland. Woohoo!
Ooh.
Love our
Hello, can we come visit you?
And thank you for your podcast. I am soon 36, husband's 34. We've been trying to conceive since August of 22 and since no pregnancies. Blood work and semen analysis done in a private infertility clinic January of 23. All normal, FSH 5.2, LH 2.9, AMH 6.46, and ultrasound
Good.
showed 20 follicles on the left and 10 on the right.
Great.
Cycles are normal. I went through 6 letrozole cycles in 2023. We got an appointment to the public infertility clinic in November of 23 and got in the IVF queue, now waiting for treatment. In November, doctors only saw 12 follicles on the left and 10 on the right ovary. AMH 3.07, FSH 4.9, LH 3.4. What might have happened during 10 months with AMH? Should I be worried that my ovaries have started to diminish?
No. So your AMH, from what I recall, went from 6.46 to 3.07, or at least that's what the lab showed, right?
Yes.
Yes. 6.
So those are
Yeah.
So those are both great numbers. I don't really think that your ovaries have really changed that much. I think if you checked it 1 or 2 more times, you get a different number. But the bottom line is both of those numbers are really good. And so, you might, maybe worth checking it one more time. But I don't really think clinically anything has changed inside of you. You're a 26-year-old. You're really young. So I don't think that there's, I'm sorry, you're 26 or
Oh,
36.
36.
36.
36. Yeah. So, I mean, we do worry every year that egg quality can diminish, and also egg number, and AMH really looks at egg number, but I really doubt that clinically is significant. I think if I had a patient at any age that had an AMH of 3, I'd love that. That'd be great.
So I think that, yes, it's possible things may have actually diminished. I mean, some of it depends on what overall life circumstances are. Some of it depends on, was there a cyst on this most recent one that was blocking some of the view of what they could see for the antral follicles. There's changes that are decreases that are just there, and there are changes that are decreases that are clinically important. Right now, I would agree with Abby. I don't think this is a super clinically important piece, especially because you're already in the queue for IVF. And so that means that you're already well on your way to just doing the most definitive treatment that's available. And so I think in your specific situation, I don't know that makes a whole difference. Now, if it was going to be 6 years before you could actually get into do something about it, I would be a little bit more bent out of shape about that. But I think there's changes, and then there's clinically relevant changes. And I think this may legitimately be a change, but I don't know that it's going to be hugely clinically relevant, because you're already in line to do what we would suggest that you do. So I think you're probably okay.
Yeah, I would say the most likely is that this may have been processed on different platforms.
Right. That
Yeah.
too. Yeah.
It's just,
Different
it's
labs.
different
Yeah.
labs do different things. I mean, even when we do AMHs here in the States, if I send it to the people who specialize in fertility testing versus the people who don't specialize in fertility testing, we can get some results, but most of the time it's not, as we've mentioned, it's not clinically important.
Mm-hmm.
All right, our
All
next
right.
one. I have very long cycles, 40 to 50 days, and was diagnosed as infertile age 38. Endometriosis, PCOS, and thyroid tests all negative. Prior to diagnosis, I used multiple tracking methods to time intercourse while we were trying. I will be starting letrozole medication and trigger shot and timing intercourse soon. First, is tracking worth it once I begin cycling with my new clinic using medications to stimulate ovulation? And are there other better fertility tracking methods? I hate having to collect my urine, and I haven't found any other reliable ways to check ovulation.
I mean, it kind of depends on what you're going to do with your other fertility clinic. And I can't remember if you said you've done any medicine at all, but a lot of times when people do medication, particularly if they're going to do intrauterine insemination, your fertility doctor will probably want to track you with ultrasound. The advantage of ultrasound is it tells us that you have a mature follicle, and it kind of gives us a sense for when you should come in for your IUI. And so if they do that, you don't necessarily have to do ovulation predictor kits. You can, particularly if you hate doing them, you can just leave them behind, because really they'll base when they do the insemination procedure on what they see on ultrasound and not on what your predictor kit shows.
I typically, uh, in most situations, would rather just totally rely on the ultrasound and the HCG, primarily because I've had some people where they were taking usually letrozole and doing the urine kits, and it registered as high that they were ovulating, and they were nowhere near ovulating, but because of the way the medication worked, it bumped their LH just a little bit to trigger the test to look like it was positive, even though it wasn't actually. And that ends up increasing your number of visits to the office, increasing your anxiety because you think you're ovulating when you're really not. And it's a little bit more of a headache. So I tend to not generally want people to do that. Now, you can get burned in both directions from that. One, from having it a false positive, the other from missing a true positive.
That's
So yeah, I mean, you can kind of go back and forth, but most of the time I have found that I think it increases people's anxiety without improving their clinical outcomes. And so as much as missing a month really sucks, it's I tend to take that a little bit more because people's anxiety is high enough. Just
Yeah.
Flips
existing.
to wake up in the morning and the first thing you think about is your fertility.
I know. Yeah.
Yeah.
Like
But
it's just another way to make you a little bit more anxious each day. So let us take the stress off of you. We're going to do the ultrasounds. We're going to trigger your ovulation. Don't worry about peeing on a stick.
the one time I would say that could be helpful is, like, say you have a patient that has a 16 millimeter follicle when they come in, which is a little bit smaller than what we like to see. And the patient doesn't really want to come back the next day, and they're trying to time when they're going to come back. I would usually say, well, why don't you do an ovulation predictor kit tomorrow? As long as it's negative, then just plan on coming in the following day and we'll look with ultrasound. And usually by that day, the follicle would be ready. But every now and then you get patients, particularly patients that are older, their eggs tend to be a little bit more difficult to manage. Every now and then you'll get somebody just once every blue moon that will ovulate when they had a 16 the day before. And you're like, what? But for most people with a follicle that size, they could go another couple of days and they would be fine. But that's the one situation where sometimes I'll tell people, yeah, go ahead and use an ovulation predictor kit.
All right, you ready for another one?
Let's do it.
All right, I'm 32 years old, husband 35, and trying to conceive for 8 months with no luck. Decided to get a few tests run. Husband semen analysis, all normal or above average. Did blood panel 1 week before my period to confirm ovulation at 19.6, AMH 3.24, TSH 2.3. Prolactin came back as 53.6. Doc diagnosed me with hyperprolactinemia and ordered an MRI suspecting a tumor on my pituitary. Her suspicions were right, and results show a prolactinoma. She referred me to an endocrinologist, but I can't get in for another 2 months. I have no other symptoms of this tumor, no vision issues, no headaches. Cycle is normal, predictable, positive OPKs. Could my high prolactin levels be the cause of my fertility issues? Any info would be appreciated. I can't seem to find much on this topic. Thanks.
So Depends on the comfort level of your doc of what you do next. I think particularly if you don't have any other symptoms at all, might be reasonable to start low dose of like cabergoline. There are generally two medications that are used to address high prolactin levels. One is cabergoline, the other is bromocriptine. Most of us tend to like cabergoline a little bit better. You do not have to take it as often. It's a low dose, and the side effect profile is a lot better. So bromocriptine has been around forever and a day, but a lot of people don't really like being on it. So cabergoline is going to be the go-to place to start. If it's something that you're likely to be on for a very long time, oftentimes they'll order cardiac testing as a baseline just to make sure that your echocardiogram is good. But it's something that, particularly with an otherwise totally negative history, you might be able to start it a little bit earlier. I think if you need to wait the couple of months because your doc is not comfortable and they do want you to see the endocrinologist, I don't think that's going to harm you. My main hope for you is that once you get it treated, that things work just a little bit better. You know, even when someone is ovulating, they have regular cycles, that prolactin can interfere a bit. And so we tend to see nice results when people go on that medication and you have the start of the testing. So if you've been on it for another, 4 or 6 months and still don't have a baby, then you just get a little more aggressive and go to the next step.
One other question I had, she didn't mention breast discharge, and she said she had no symptoms, so I'm assuming she had no breast discharge, but it would be interesting to know if you had that, because even if you can have any little bit of nipple discharge, that kind of tells me something's going on in there, and it can be helpful to start on Dostonex carbogoline. The other thing about your prolactin, and probably your doc knew about this and did this, but for people who are going to have prolactin done, you want to have it done fasting. You want to have it done that you haven't, not a big meal for breakfast. Ideally, you don't want to have sex for 24 hours beforehand. You don't want to exercise because sometimes sports bras can irritate your nipples and that can increase it. And any kind of nipple stimulation with intercourse or whatever is something that can also increase your prolactin as well. So just make sure that you've kind of followed those rules. A lot of times I'll do a baseline prolactin on patients if I'm worried. And then if it turns out to be elevated, I'll bring them back after they've done those things, just to really make sure that it's a really true value. And of course, in your situation, you did find that you had a tumor. And so therefore, I would say probably you're going to be started on medicine. It's just a matter of when. So like Carrie said, definitely, I would go ahead and get you started on carbogoline at this point for sure. You're going to be on it.
Absolutely. And also prolactin's one of those types of hormones that we only check about once a month, once we do an intervention. And so normally with cabergoline, you'll start off with maybe like a half a tablet twice a week or that type of thing. And then we'll gradually titrate you up. Some people need a little bit, some people need a little bit more. And some of it's going to depend on the size of your prolactinoma. But I think 2 months isn't the end of the world, but if your doctor's comfortable starting that kind of gets you a little bit ahead of the game.
Yeah.
So, all right, let's see. Our next one is, good afternoon. I'm 32 years old. Husband is 42, living in Florida. Tried to conceive for over a year and had a miscarriage in October. I'm currently starting the process of IVF. Got all my labs done, tubes checked, semen analysis, and genetic testing. I'm an SMA carrier. My husband is a silent carrier, 2+0. My fertility doctor requested PGTM testing, but was denied because the genetic counseling team, doesn't have enough evidence that my husband could be a carrier. Question, is this a common policy to be denied services based on this testing? Based on your experience, is it relatively safe to proceed with treatment without the PGTM test?
I would get the PGTM test. SMA is a really challenging genetic condition to talk about. It's an example I always use when patients start asking me a lot of genetic stuff. I'm like, SMA is a common condition, but it depends on where it's located on the gene, if it's cis or trans, and whether it could be an issue or not. To me, you're kind of playing with fire. Me personally, I think it'd be worth every penny of paying out of pocket to check your embryos because that condition can be a really scary condition. And as
I
Carrie,
think I think the lab is declining them to test their embryos. So,
I see. Oh, okay.
For our listeners, if you have a genetic condition that we're potentially doing PGTM, which is the testing on the embryos to see if that specific condition is going to, how many copies are present, we have to send all the genetic result to the lab, and the lab decides if they can make a probe for it and whether it's clinically significant for with the 2 mutations that are noted in each partner, whether it's likely to result in an abnormal baby. And so what I'm hearing from this is they've had that information sent to the lab and the lab has declined them for PGTM.
Oh, I heard it differently. I heard it that
I-
insurance was
Insurance
declining
wouldn't,
them.
yeah. Because I don't know why the lab would decline that, because they could still test for the, for if the baby was affected or not, and at that point make a decision.
No, I'm pretty sure that it didn't say that it was declined by insurance, it was declined. I think this was one of those where the lab calls back and says, no, we don't offer testing in this situation. I've
Hmm.
had that happen.
I've had
Which,
that happen too, but it hasn't been in this particular scenario. So usually when it's the lab declining you, it's because they don't think
they
they can get the
tested
accurate information
from
because
your
that's very
parents or your
different.
siblings.
Right.
Which is interesting because if it's a 0+ 2 kind of possible carrier, the embryo should show that.
Yeah. It'd just be whether it's cis or trans, and it'd be a call whether or not the embryo was really affected with it, not whether or not they could find it or not. So it wouldn't, to me, it doesn't make sense that it would be the lab that would decline it. It'd be the insurance. So I don't know.
I think for our listener, whoever this is, going and having a genetic counseling appointment with
Yeah.
the actual lab that was giving these comments will be able to help you get some better information. And they should be able to explain to you your risks. And it may be a situation that they need more genetic information from additional family members. I know that that can be an issue sometimes in silent carriers. And so that may be an additional step that may need to be happening.
You can
But yeah, I
get
think
second opinions from labs as well. It's not like
mhm,
there's a huge number of labs that do this, but there is more than one. And so,
mhm.
that may be something where there's a handful of places that can do this. And it may just be talking to someone else to say, hey, do you have the capacity to do it? And them being able to tell you this is the amount that we think we are reliably able to get that information versus not is important, because even though you have the testing, it doesn't guarantee that you're going to get results. And
Mhm.
some of that is related to how detailed the testing is, because the more detail you get, the harder it is to get that detail. So sometimes you just don't get an answer. It's not that it's bad, and it's not that it's unusable. It's that you don't know. So that might be worth a little bit more looking into.
And I would add in, if it is an insurance question, so say you're saying, okay,
Yes.
it can be done, but we don't know if it's worth doing it. That's a personal decision for each individual couple. But I think most physicians and most geneticists would recommend that you, in fact, do PGTM. I think in the long run, you'll be glad that you did that if you find out, because your chances are you're going to have some that are affected and some that are unaffected. And certainly, I think everybody would want to transfer an embryo that wasn't likely to get SMA.
Yeah, and insurance companies, they make their money by not paying for things. So, keep fighting. Doesn't always make sense.
Doesn't
Absolutely.
necessarily mean that we would agree with that.
Mhm.
All
Okay.
right, one more.
All right. One more. Hello. Recently started trying to conceive journey. She's 31 years old. uh, After being on OCPs for over a decade. Stopped in August. Decided to get all upfront testing done to see if we need to freeze eggs, etc. Had an AFC of 13, 8+5 on cycle day 3. AMH was 15.6.
Uh,
Picomoles per liter. I think this person is from the UK. So it would be equivalent US numbers of 2.18 nanograms per milliliter.
Mhm.
Did some searching for optimal reference ranges, and some say that this is ideal. Other places says it means diminished ovarian reserve. Left feeling confused and can't stop worrying. Doctor not very helpful. Please help me figure out what I'm working with here. Thank you. Well, thank you again for another one of our listeners over in Europe.
so she is asking if her AMH of 2.18 is
Is
equal to
normal or
decrease
diminished
over.
ovarian reserved?
I think that's fabulous. I would love to have somebody with an AMH of 2.18 that's 31. I think that looks great. Yeah.
Yeah. And the other thing is being on OCPs for 10 plus years, that will have a somewhat suppressive effect and that will lift over time. I would, depending on when she had that drawn, if that was drawn within a month or two of her coming off OCPs, she still might be suppressed from the OCPs.
It
And
may
it's
be
not a
better.
permanent suppression, it's a lab suppression. And so I wouldn't expect that to really have a huge impact on her outcome, especially if she's waiting a couple months to let that lift. But yeah, I mean, it's
Sounds
not a
great.
bad place to be.
Agreed.
All right. Well, thank you guys. To our audience, thanks for listening and tune in next week for more. Be sure to subscribe and leave us a review in iTunes. We'd love to hear from you. You can also follow us on Instagram or Facebook. Leave us some suggestions for our upcoming IVF book, and don't be a stranger.
You can visit us at fertilitydocsundcensored.com to submit specific questions you have about infertility. All questions will be answered anonymously on our Ask the Doc segment, so don't hold back. We love episode ideas, so let us know what you want to hear.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon. Bye.
Bye.
Bye.